From ARUP Laboratories on the campus of the University of Utah, welcome to the LabMind podcast. I'm your host, Dr. Brian Jackson.
Today is Tuesday, the 18th of February, 2025. Our LabMind topic for today is dementia and how and why clinical laboratory testing has become so central in the diagnosis and therapy of Alzheimer's and related dementias. Our guest today is Dr. Qinwen Mao, professor of pathology at the University of Utah, where she directs a research laboratory developing biomarker tests for diseases such as Alzheimer's, as well as frontotemporal lobe dementia. Dr. Mao received her MD and PhD degrees from the 4th Military Medical University in China before emigrating to the U.S. more than 25 years ago. She completed pathology residency as well as a neuropathology fellowship at the University of Texas Southwestern Medical Center. She later joined the pathology department at Northwestern University's Feinberg School of Medicine in Chicago, and then later joined the faculty here at the University of Utah. I also want to mention that Dr. Mao will be presenting an upcoming webinar entitled Innovations in Diagnostics for Alzheimer's Disease and Related Dementias. The information is on ARUP's website where you can register. And of course, we'll put the link for registration in the show notes as well. Dr. Mao, welcome to LabMind.
Thank you. Glad to be here.
So I recognize that neuropathology, from the perspective of pathology as a whole, is pretty subspecialized, but there's still a lot you can do in neuropathology. You can study cancers, you can study lots of interesting autoimmune diseases like multiple sclerosis. What was it that led you to devote your career to dementia, of all things?
I think this is because all of the opportunities that have been provided to me. In 1998, I came to the US and started as a postdoc working on gene therapy for neurodegenerative diseases. That was my first real encounter with dementia. It was a truly rewarding experience with a few of my papers published in top journals. In 2007, as a neuropathology fellow, I first learned how to diagnose Alzheimer's disease using neuropathological techniques. In 2010, I joined Northwestern as a neuropathologist. I had a wonderful mentor, Dr. Eileen Bijou, who was internationally renowned and a pioneer in frontotemporal lobar degeneration FTLD research. The ADC center there we worked for has world-class neurologists, and I learned so much from them. During our monthly clinical pathological correlation meetings, I saw firsthand just how much patients and their families were going through. That really stuck with me, and since then, I have spent most of my time focused on clinical work and research on frontotemporal lobar degeneration and Alzheimer's disease. This is what led me to dedicate my career to dementia research.
So this seems like a common theme in academic careers, that when you have a really strong mentor that ends up steering you in a particular direction that can be quite productive. Let's talk a little bit about that conference that you mentioned a moment ago. When we spoke earlier, it sounded like you had an impactful experience talking with someone. So could you set the stage here for what that conference was and what your experience was there?
It was an education conference with an audience mostly made up of caretakers, patients, clinicians, and researchers. I was one of the 3 panelists sharing our research progress on dementia biomarker development. After meeting, many family members came up to me expressing their gratitude to our work and asked when the test would be available. Those conversations really stuck with me. They made me feel that, as researchers, we haven't worked hard enough to truly help dementia patients.
This certainly is a really high social impact disease. I had an uncle growing up, and he was this brilliant actor and theater director who was the Dean of Fine Arts here at the University of Utah and directed and produced the theater on campus. And then when he was about my age, which I'll confess is roughly mid-50s, his personality changed. He just wasn't as smart. I remember talking to him and thinking, what's wrong with Keith? He doesn't seem to be cluing into things, and he's not as sharp as he used to be. We didn't get a diagnosis till after he died and there was a brain autopsy. But he had a form of what you study, frontotemporal lobe dementia. It destroyed a good decade of life when he should have been in a really productive phase. It also took away about a decade of his wife's life as a caregiver. The impact is incredibly huge. Do you often run into people, either in your neighborhood, on the street, in the grocery store, who hear that you study this area and want to talk to you about it?
Yes, actually. At this year's neighborhood Christmas party, a lovely woman and her husband came over to say hello. She told me that her family has a history of genetic FTLD, and most of her relatives who suffered from this disease passed away in their 60s. She had done a lot of reading about the disease and found out online that I work on FTLD research. Then she said something that really hit me. Every day, she feels like she is sitting on a ticking time bomb, wondering when the disease will strike her. Yesterday, her daughter, a brilliant high school senior with straight A's, came to my house to ask for advice on how to become a neuropathologist or neurologist. When you personally know someone facing these devastating diseases, it makes you feel like you haven't worked fast enough to help them.
So given this enormous social impact, I'm trying to think of other diseases that have the same level of impact. I think of HIV during the 1990s that didn't impact nearly as many people, but it was really scary and had horrible effects on the people it infected. And as a result, government funding was massive and led to some really huge breakthroughs to where HIV is not quite cured, but almost cured. I mean, incredibly manageable. We don't have anything close to that for Alzheimer's or frontotemporal lobe dementia or these other forms that you're talking about. What is it about these degenerative brain diseases that has made it so hard?
Let's first talk about what's the most common types of neurodegenerative disease. Alzheimer's disease is about 6 to 80%, and the Lewy body disease is about one of the examples for Lewy body disease is Parkinson's disease, is about 5 to 10%, and the frontotemporal lobar degeneration is about 5 to 10%.
And I'm guessing that in the absence of good diagnostic testing, everyone would just lump all these together and call them Alzheimer's, even though they're not all technically Alzheimer's.
No, it's not Alzheimer's disease. As the research and clinical diagnosis evolving, and those subtypes become more and more clear to us.
So why has this been such a difficult area to study and develop therapies for?
Using Alzheimer's disease as an example, why the treatment for it is so difficult? It is because it's a complex and multifactorial nature, and the late diagnosis and the irreversible damage of the brain. In addition, there is a brain-blood barrier limiting drug delivery, and also it's very difficult to clear amyloid and tau in the brain. Many failure of clinical trials, but we still have hope. For example, emerging therapies like new approaches like gene therapy, stem cell, and also improved early diagnosis like a blood-based biomarker.
So it sounds like you're still optimistic that therapies will come.
Yes.
So let's dive into the different disease categories that you mentioned a moment ago. So you said that Alzheimer's is the most common of the degenerative causes of dementia. Your laboratory, as I understand it, focuses especially on frontotemporal lobe dementia, which I think has a lot of symptoms in common, but could you describe that and how it's both similar to and different from Alzheimer's disease?
Sure. AD and FTLD shares a lot of similarities. For example, they both neurodegenerative disease. Both can cause memory loss, behavior changes, and difficulties in daily functioning. And they both have protein aggregates and no cure so far. They have a lot of differences. For example, the brain region affected is different. AD, mainly hippocampus temporal lobe. FTLD, like its name, frontotemporal lobar degeneration, is involving frontal and temporal lobe. And early symptoms are different. For FTLD, behavior changes is more prominent, and also language. For AD, the earlier symptoms is memory loss. Onset age is also different. For FTLD, it's younger, usually 40 to 60s, but for AD, usually is older than 65. Proteinopathy is different. For FTLD, there are two types. One is tau, another is TDP. TDP is area my research interest. For AD, it's proteinopathy including amyloid and tau. Progression for FTLD is faster, but for AD is slower. Genetic links is different. FTLD can have genetic factors including MAPT, progranulin C9, but for AD, ApoE4 is strongest factor.
I was in medical school about the time that my uncle died. And my memory is that at the time, they were mainly distinguishing the frontotemporal dimension, which he was referring to under the name of Pick's disease, from Alzheimer's, partly based on symptoms, as you pointed out, and partly based on the brain region affected. But I don't remember at the time any discussion of molecular differences between the two. Are the molecular markers in frontotemporal lobe dementia relatively recently discovered?
For molecular marker for frontotemporal lobar degeneration, as I mentioned, there are two types, FTLD tau, like Pick disease, and FTLD TDP. Especially for TDP, this TDP43 and this molecule actually was only described its function in FTLD in 2005. It's pretty new.
So when we talk about FTLD or frontotemporal lobe dementia, some of the listeners may not have heard that term before, or they may have possibly heard the term and can't remember where they heard it. But aren't there any famous people who have had this disease and been in the news?
Oh yeah, there is a famous actor, Bruce Willis. I really like his performance, like in Friend. He suffered from FTLD. And he actually helped AFTD, Association of Frontotemporal Degeneration, improve their exposure to the world.
So you've talked about clinical factors, you've talked about genetic factors, and then you've talked about the actual proteins involved that we now have tests available for. Can you talk in clinical terms how these diseases have historically been diagnosed and how this is evolving thanks to the kinds of tests that you're developing in your own laboratory?
Back to my old time when I was a fellow, when a patient saw a neurologist, the diagnoses were based entirely on symptoms. It was a syndrome diagnosis. For the neurologist, the doctor didn't actually know what was happening at the molecular level or what proteinopathy the patient have. It wasn't until after the patient passed away that a neuropathologist could confirm the diagnosis through a brain autopsy. Like for AD, the proteinopathy, amyloid, and the tau was found a while ago. But for TDP43, in FTLD, it's actually the research on this area is evolving very, very fast. So that's why all those researchers have been helped develop the liquid biomarker and so enable the patient to be diagnosed when they're still alive, still have the opportunity to receive treatment.
If the definitive diagnosis isn't until after death, that doesn't give you an awful lot of practical information to work with in terms of therapies, I imagine. I worry about clinical diagnosis just based on symptoms because I'm guessing there's probably a fair amount of overlap among the different diseases. Is that correct?
Exactly. That's called heterogeneity. For one disease, like for Alzheimer's disease, it can have a different presentation. Most of them have memory loss, and they also can have behavior changes, language problem. And for single symptoms, language problem, behavior changes, it can have many underlying molecular diagnoses.
So clinical diagnosis by itself is going to lump a lot of different molecular processes under the same heading of basically dementia, but it's not going to be terribly useful in terms of developing therapies. So could you talk about why it is so important not just to understand the molecular basis of these diseases, but why is it so important to actually have tests that can distinguish at the molecular level?
The key questions is to diagnosis. The patient is still alive, even early diagnosis. They have the opportunity to get the treatment earlier. So that's a reason. And for over the years, there is an imaging diagnosis like PET scan, amyloid deposit, tau deposit. Those are very expensive and invasive. And then there is CSF diagnosis. It's also invasive, but it's quite accurate. Nowadays, especially over the last few years, blood biomarker is a hot topic. And there is one success, p-tau217 is a successful blood biomarker for AD. Our lab, and with the support of ARUP, are working on TDP blood biomarker. We already have obtained very promising results, and hopefully in the next few years, ARUP can make it available to the clinic and hospitals.
So anything that you can measure on blood and doesn't require a spinal tap, it sounds like that would make the diagnostic testing more widely available.
Right, and non-invasive.
You mentioned earlier that the molecular changes are irreversible, which seems to be a key issue here. If these changes were reversible, then diagnosing early wouldn't be nearly so important. But if you can't reverse it, it seems like we would want to be able to diagnose this quite early before the brain starts deteriorating. About how early can Alzheimer's and FTLD be diagnosed using biomarkers?
For diagnosing AD at the MCI stage, like when the symptoms onset 5 years before dementia, is early enough for treatment benefit.
So MCI, mild cognitive impairment, is that correct?
Correct. That also means when the symptoms first start.
It sounds like we don't have tests yet that could pick this up pre-symptomatic.
Actually, we have some good news. CSF marker I mentioned are highly accurate in detecting AD pathology when MCI, mild cognitive impairment, starts. And before symptoms, like a preclinical stage, CSF changes can occur 10 to 20 years before symptoms start. So this CS test can make it useful for early detection. But for blood biomarker, p-tau, like p-tau217, is highly accurate for diagnosing AD at MCI stage, have a 19% accuracy. And even at preclinical stage, p-tau217 can show a comparable accuracy to CSF and PET imaging, make it promising for early detection and screening. But for FTLD, there is more challenging than AD diagnosis. So far, there are no biomarker is reliable for diagnosing, especially sporadic FTLD.
At least not until the late stages, or not at all?
Not at all. The biomarkers are still mostly research tools.
So there's another benefit of biomarkers that I'm hoping you could talk about, and that is in clinical trials. So even separate from using these tests to diagnose in individual patients for purposes of treatment, to the extent that treatment's even available at this point, could you talk a little bit about why specific biomarkers are important to the pharmaceutical side of research and development in clinical trials?
Yes, of course. Liquid biomarkers, CSF blood biomarkers, are essential for clinical trials. They can improve patient selection, measure treatment response, and track disease progression. p-tau217 now is a game changer, makes trials more accessible. Biomarkers will continue shaping AD drug development, especially for preclinical interventions.
So to pick a completely different type of disease, I think of depression in psychiatry. There are antidepressant drugs available, have been for years, but development and improvement of antidepressant drugs has always been held back by the fact that the diagnosis is just clinical. There are not good molecular biomarkers, and it makes it very difficult to know, for example, a drug theoretically might treat one subtype of depression, But if you're running a clinical trial where that subtype's mixed in with a whole bunch of other people, you mentioned patient selection, it can really interfere with the ability to run that research. So even if we don't have a whole lot of effective treatments today for Alzheimer's, which let's just face it, we don't, let alone frontotemporal lobe dementia, these tests should open up the possibility of more effective research into therapies in the future.
I agree. And I'm hoping it's soon to become a very easy, effective test.
So I understand that in addition to degenerative diseases such as Alzheimer's and frontotemporal lobe dementia, that you also study chronic traumatic encephalopathy, a disease that is in the news a lot as well. For example, football players or military veterans. What do we know about the molecular basis of chronic traumatic encephalopathy?
Chronic traumatic encephalopathy is a neurodegenerative disease associated, as you mentioned, with repetitive head trauma commonly seen in athletes, military personnel, and individuals with repeated concussions or subconcussive impacts. The molecular mechanism of CTE shares similarities with other topsy like Alzheimer's disease, but CTE has distinct pathology linked to repetitive brain injury. Under the molecular level, CTE is primarily a tauopathy with unique perivascular tau aggregate.
Are there any laboratory tests which are either available or under development for CTE?
Currently, CTE can only be definitely diagnosed post-mortem, but there is active research into biomarkers that could enable in vivo diagnosis. Efforts are focused on identifying blood, CSF, and imaging biomarkers to detect tau pathology, also neuroinflammation and axonal injury. The future research aims to develop non-invasive screening tools for high-risk individuals, such as athletes, military personnel, and therapeutic trials, such as anti-tau therapies, neuroinflammation modulating drugs.
Now, you mentioned that the physical mechanism here is repeated physical injury, and you mentioned concussions, which I think is a synonym for traumatic brain injury. Is that term correct?
That sounds correct, yes.
I believe I've seen things in the news about laboratory tests for traumatic brain injury. What's the status of that?
There is research on blood biomarkers such as neurofilament light chain, GFAP, even p-tau217. Those tests could improve real-time traumatic brain injury diagnosis and guide safer return-to-play decisions. Future biomarker research may allow for earlier identification of high-risk individuals before CTE develop.
That would be fantastic. For my final question, there's a lot of discussion right now, but I think perennially, about how much money we spend in this country on basic medical research and whether all of that money is actually beneficial. And shouldn't we just let the drug companies do their research and development? Why do we need to be spending money on more upstream basic science? How is your research lab funded? Do you have grant support from the NIH, for example?
I have support from NIH grant, but not enough. Research money to hire people to set up any model is very crucial for the progress of the research. And this research is fundamental for test development and the treatment development research. Those are very, very crucial.
Sometimes basic science research gets criticized because it's not directly producing therapies for diseases, but without the basic science research, is it possible to develop therapies later on?
I don't think so. Basic science is a foundation for biotechnology development on all aspects.
So both from a medical perspective of developing the therapies, but I think you could also argue from a business perspective, in order to have a biotechnology industry, there needs to be a really strong foundation of basic science. Wouldn't you agree with that?
Yes, of course, I agree.
All right. Well, Qinwen Mao, thank you so much for being on LabMind today and sharing your expertise about degenerative brain diseases and biomarkers and where the science is going.
Oh, my pleasure. Thank you for this opportunity.
LabMind is sponsored by ARUP Laboratories, a not-for-profit enterprise of the University of Utah and its Department of Pathology. Our producer is Cherie Peterson, with audio engineering by Isaac Acosta-Alvarez. You can also find other LabMind episodes at arup.utah.edu, along with an extensive video lecture library providing free CME and CE credits for medical and laboratory professionals. Subscribe to LabMind on Apple Podcasts, Spotify, or your other favorite podcast app, and please leave a rating and review in order to help others find the podcast.